Okay, and we are live. Good morning, web shadowers. Thank you all for joining our session today. Today we have the pleasure of welcoming Dr. Elborno again. She's an OBGYN. As always, please remember the Google form will be posted in the comments and on our Instagram bio at the end of the session. With that being said, Dr. Elborno, you can start whenever you're ready. Oh, you're muted.
Hi, everybody. It's so nice to do this last and final lecture in the series that I created for web shadowers. In today's lecture, we're talking about heavy periods at the start of menarche and what that could be a sign of and how we treat it. But I also wanted to review a little bit more about my background and what I studied in college, how I applied to med school, what my AMCAS looked like, and things like that. So I'm just going to go to presentation mode. So just to review who I am again, so I am an OBGYN and I was a traditional medical student. So I went straight from undergrad to med school. And in undergrad, I actually majored in journalism and I had a minor in Islamic world studies. I was pre-med with those majors, which means that I did my pre-medical school prerequisites and I actually crammed them in to finish them in the first 2 years. I know most times you do your prereqs in the first 3 years and then take the MCAT and apply. But it was a huge goal of mine to study abroad in somewhere. I really wanted to study abroad in undergrad. So I finished my prereqs after the second year of college and I studied for and took my MCAT in the summer between my second and third year. And then during my third year, I studied abroad in Tunisia. While I was in Tunisia, I did a lot of my journalism credits there. The program that I studied abroad with was specifically a program that looked at media in the Middle East. So I was able to do a lot of my journalism credits while studying abroad in Tunisia. And I came back and finished my fourth and final year of college, applied to medical school, and was accepted into a couple different medical schools, both in Chicago, Boston, Portland, and ended up staying close to home in Chicago. I think that one of the things that I thought about was just having that extra support system of being close to home. And that was definitely something that inspired me to stay where I did at Stritch for medical school. I loved that medical school. It was such an amazing experience. And I would still say it's like one of the happiest times of my life really was medical school. I really liked it. It was hard. It was challenging, but I felt like it was such a golden era because I was done being a pre-med. I knew I was in med school. I was finally doing the thing that I wanted to be doing. And honestly, you have a ton of time to study and to learn. Yes, you're in classes, but everything's really online and your time is your own. And the major timelines are really just to study and to learn and to absorb as much information as you can. So I'm kind of a book nerd and I just loved having time to study and to finally be studying the things that I did. I think that some of the things that made my application competitive to medical school was one, I think that in college I had kind of a unique background. I studied the things that I truly wanted to study. I didn't study biology as my major just because I thought I had to. I truly really enjoy journalism. I was really interested in using words to advocate on someone else's behalf and what is the scope and the breadth of language that we have that we can document history in real time. So that was something I was interested in and I wanted to study it. I'm also Muslim and I really wanted to study Islamic world studies in an academic way and to have an opportunity to learn about both like the history and the context of Islam and things that, growing up being Muslim, you don't necessarily have a chance to learn about. So those, I think, were some things that made my application competitive. I also did volunteer at a children's hospital throughout my time in college, and I had a lot of volunteering hours at the children's hospital under my belt. While I studied abroad in Tunisia, I did a large research project. My journalism thesis there was studying sexual harassment in public spaces, and that was the investigative report that I did. So it really infused some of the language of my application with women's health advocacy and learning about the role of women in different contexts and thinking about how being a physician allows you to advocate for patients who are under-resourced, underserved, and really gives you a voice in any context to immediately fit into the society and know how to help. So that was sort of the angle that I took with my personal statement. And I think that ultimately that probably made my application stand out a little bit from the crowd. And I think the reason I want to share that with you guys today is that I want you guys to be the most genuine versions of yourself and don't feel like you have to water yourself down to fit into a mold of what it means to be pre-med. I think at the end of the day, medical schools want people who are genuine, who are passionate, who are well-rounded, who are mature, who know what they like, who know what they're interested in, and who've really had an opportunity to explore their passions outside of medicine and to really prove that they know that they want to be physicians. And yes, it's strong to say that you've only done medical stuff, and that you want to do this, but I think it's even stronger to say, I do like things outside of medicine, I've explored them, but I keep coming back to seeing myself in this field for X, Y, and Z reasons. I think that that just shows a different thought process and a different kind of scope and breadth of life experience. And I think that life experience is really important when you want to become a physician because a lot of the things that you deal with, both in medical school and residency and out on the job, require a lot of maturity and require a lot of kind of readiness to deal with heavy things. And um, I think medical schools want to admit people who are kind of primed and mature and ready to handle that. So showing that you've been through different life experiences and that you've, put yourself outside of your comfort zone and are able to say, like, I explore the land outside of my comfort zone often and I thrive in that environment. I think that's really powerful. I think that's really strong. So ultimately, like I said, I went to Stritch School of Medicine, so that's Loyola University of Chicago's medical school. I went there for medical school, and that was 4 years. But I actually took a year off between my third and my fourth year of medical school to do a Fulbright scholarship in Jordan. So I did a Fulbright looking at um, research for diabetic populations amongst refugees in Jordan. So I worked with Palestinian, Syrian refugees in Jordan at UN health clinics and helped apply a randomized control trial for a diabetes health education program. So they essentially created three arms the of the cohort, and one of the arms was using a social network tool to learn about diabetes health education. And they had to use that with somebody who's actually in their social network that they see on a pretty like day-to-day basis, like a sister, a neighbor, something like that. And then we compared that to people who went through the diabetes health education program individually to people who didn't have any diabetes health education. So I spent a lot of time like in clinics doing health education. And I also got to spend time in the office kind of looking at our data and preparing documents for the RCT. It was a good experience, but it definitely taught me that I really like being in the field a lot more than I like being behind the scenes and sitting in front of Excel spreadsheets. So it really showed me that I like research and theory, but not really so much in practice. And when I went on to residency at University of Chicago in obstetrics and gynecology, I developed an interest and a passion for pediatric and adolescent gynecology. It was just a patient population that I found myself really gravitating towards. And I really like being an expert in a small corner of the world. So within obstetrics and gynecology, I wanted to develop that niche expertise. So I spent a year in Toronto at Sick Kids Hospital studying pediatric and adolescent gynecology. And I completed that fellowship, and now I'm in my first year of work outside of training, which is a whole new learning curve all on its own, and is definitely a conversation for a different day. But I will definitely say that you really truly have to be a lifelong learner to become a physician, because it really never stops. Like, already from the time that I trained, there's different guidelines and different evidence, and the practice is already different and changing. So sometimes it's funny, like my older colleagues will hear me say, well, when I trained, like, this is what we were doing. They're like, oh my gosh, Jana, that was like 2 years ago. But somehow things are already different. So truly have to be a lifelong learner. And for anybody working on a medical school personal statement, I would really emphasize that you love lifelong learning, because that's truly one of the things that they're looking for. So let's get into the meat and potatoes of our talk, and get more into our case for today. I hope that little review of my background was helpful, and of course, feel free to reach out to me. I try to get back to people. This past week has been so busy, but certainly reach out to me if you have any questions about it, and I'll be happy to try and respond to people. So like we reviewed in our last talk, puberty is a series of physiologic and neuroendocrine events in which a person develops secondary sexual characteristics. And for an assigned female at birth, someone with an XX sex chromosomes, the ability to ovulate and menstruate is also the end landmarks of the pubertal arch. It's a 2 to 4 year time span starting between 8 and 13 years old for 98.8% of the population. And it goes in an order like this. First, you have some breast development, then you go through adrenarche and gonadarche, which is a neuroendocrine awakening of the adrenal glands and the gonads to start making some male-type hormones like DHEA, DHEAS, testosterone, DHT. And then pubarche is the clinical finding from adrenarche and gonadarche, where you actually see pubic hair, underarm hair, clinically. And then you have a growth spurt where you start to have an exponential increase in your height. And then you have menarche. And menarche is usually the last part of the pubertal arch. We stage the phases of puberty with Tanner staging. 1 is nothing, and 5 is adult pattern breast and pubic hair development. So just to quickly review the menstrual cycle for people who weren't with us during our PCOS talk. Day 1 of the menstrual cycle is the first day of your bleed. And day 1 is when the endometrial lining is shedding. While that is happening, what's happening in your HPO axis is the following. Your FSH, which is your follicle stimulating hormone, you can see at the beginning of the cycle, it's starting to rise. As it starts to rise, it gathers a cohort of follicles that are going to start making estrogen. FSH stimulates a handful of follicles from the ovaries every month to start making estrogen. As estrogen starts rising, you can see that gold line, it's going to have a negative feedback on the FSH, releasing cells in the hypothalamus. And FSH is going to start to drop. The best of the follicles in the ovary is going to be very, very sensitive to FSH. So even though FSH is starting to drop, one of the follicles is going to become a dominant follicle and still be stimulated by FSH because it has a lot of FSH receptors. I said that FSH was released from the hypothalamus, but I meant the pituitary gland. I'm post-call, so we're struggling through some of this, but we're going to make it happen. So FSH is released from the pituitary gland, and there's estrogen receptors on the anterior pituitary that have negative feedback on those gonadotropic cells that are releasing FSH. So the more estrogen that you have, the less FSH that they'll release. And that allows for the distinction of a dominant follicle that's the most FSH sensitive. That dominant follicle, once it's fully formed, is going to spike its production of estrogen. That spike of production in estrogen is going to have a positive feedback on LH releasing cells, which are in the anterior pituitary as well. And the spike of LH is what causes the dominant follicle to rupture and release the egg in the middle of the cycle, and that's called ovulation. When the egg leaves the follicle, what's left behind of the follicle is what's called a corpus luteum, which instead of making estrogen, makes progesterone. Progesterone is the second type of hormone that's made throughout the menstrual cycle, and its role is to stabilize the endometrial lining. So you'll see in the first half of the cycle, the endometrial lining is thickening, and that's because estrogen essentially tells the endometrial lining to lay down bricks and to get thicker and thicker and thicker. Progesterone is like the grout between the bricks. It stabilizes it, it prevents it from kind of falling in a dysfunctional way. And then when the corpus luteum spontaneously regresses exactly 12 to 14 days after ovulation, the progesterone level is going to drop. So that's what erases the grout between the bricks and allows the endometrial lining to all shed in a coordinated way with day 1 of the next menstrual cycle. That's an ovulatory cycle, but many cycles in the beginning of the reproductive lifespan are actually anovulatory, because this menstrual cycle is a new language for the body to be speaking. So it's not very successfully coordinated. And many of the cycles are anovulatory, meaning that FSH is stimulating the follicles, trying to, have a dominant follicle present and cause an LH surge, but it just doesn't happen. So you have follicles throughout the cycle that are secreting estrogen. You never get that progesterone release, which means that you're constantly laying down brick in the endometrial lining, but you never get the grout. So your bleeding pattern can be a bit more dysfunctional, a little bit more irregular, because there's not that grout that's laid down to stabilize everything and then fall at the same time and allow the lining to shed in a coordinated way. So since many cycles within the perimenarchal period are anovulatory, we always ask the question of how irregular is too irregular? What should we expect as being a normal menstrual period, and what should make us think that there's pathology there? So it's good to keep in mind that the interval between menarche and regular periods is about 14 months. The interval between menarche and consistently ovulatory cycles is about 2 years. Despite most of the cycles at the start of menarche being anovulatory, the cycles still fall within a 21 to 45 day time span for about 75% of the cycles. And that would be a normal anovulatory period for a girl who's newly starting to have periods. And they still typically last about 3 to 7 days, even though they're a more dysfunctional bleeding pattern. By year 5 after starting a period, 95% of them fall within 21 to 40 days and are around 75 to 80% ovulatory. Periods are a vital sign, and we always say this in pediatric gynecology and adolescent gynecology. We always say menses are a vital sign. So just like blood pressure, heart rate, respiratory rate, O2 sat can all be clues that there is a potentially serious health condition, identifying abnormal menstrual patterns in adolescents can also improve identification of potential health concerns for both adolescence and adulthood. Bleeding patterns that are abnormal can definitely be attributable to significant underlying medical issues that have potential for long-term consequences, and we'll talk about what some of those things are. So again, the normal menstrual cycle for adolescent girls usually starts around 12 years of age. The mean cycle interval, meaning from day one of one period to day one of your next period, like we said, is 21 to 45 days, but the mean is 32 days in the first gynecologic year. So it actually is quite normal in terms of how it appears in cycle length. And the menstrual flow length is usually 7 days or less, and the menstrual product use is usually 3 to 6 pads or tampons per day. Although a long interval between cycles occasionally can be common in adolescence due to anovulation, remember only 75% of the cycles fell between 21 to 45 days, so occasionally you'll have a cycle that falls outside of that range. It's statistically uncommon for a patient to have amenorrhea for more than 3 months after starting her periods. That's called secondary amenorrhea and always needs evaluation. Girls that are consistently having cycles that are outside of the 21 to 45 day time span, where you would say the majority of their periods fall outside of that, like or every 60 days or every 70 days, that would certainly read as abnormal to me and would inspire me to do a bit of a workup. In terms of the amount of bleeding that would be considered abnormal, usually in the gynecologic textbooks, they talk about an amount that's quantified in milliliters. So they say chronic loss of more than 80 milliliters is typically associated with anemia and is a hallmark of an abnormal period. But for all the women in the audience, you know that it's very hard to quantify in milliliters how much you're bleeding. Nobody measures it like that. I mean, maybe with Diva Cups, it's a little bit easier to get a sense in milliliters, but for most people who use pads or tampons, it's impossible to know. So what we usually use clinically is a menstrual flow requiring changes of menstrual products every 1 to 2 hours, especially when that flow lasts for more than 7 days at a time. To me, that clinically sounds heavy. The causes of abnormal uterine bleeding in adolescent girls are pregnancy, immaturity of the HPO axis, so that's the most common one, is that the HPO axis is immature. There's also hyperandrogenic anovulation. So remember, that's what we talked about in our last lecture with polycystic ovarian syndrome. Congenital adrenal hyperplasia, androgen-producing tumors are also on the differential for hyperandrogenic anovulation. And then what we're going to be talking about today is coagulopathies. Coagulopathy meaning a bleeding disorder, like von Willebrand's disease, platelet function disorders, hemophilias, hepatic failure, things along those lines. Hypothalamic dysfunction can also be a cause of abnormal uterine bleeding in adolescent girls. Eating disorders, obesity, being underweight, having significant weight loss, or stress-related hypothalamic dysfunction. Hyperprolactinemia, thyroid disorders, primary pituitary disease, ovarian insufficiency, either primary ovarian insufficiency, meaning your ovaries are failing early, or it's iatrogenic, meaning secondary to radiation or chemotherapy, the ovaries are failing early. It can also be abnormal in the setting of certain medication use, whether that's anticoagulation, hormonal contraception. Also, STDs can make periods seem abnormal due to cervicitis. And then on the very, 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 very rare spectrum are things like malignancy, either estrogen-producing ovarian tumors, androgen-producing tumors, rhabdomyosarcoma of the vagina, and uterine lesions like polyps and fibroids. Polyps and fibroids are one of the more common causes of abnormal uterine bleeding in adults, but they're very uncommon in adolescents because those are estrogen receptor positive growths, meaning that they're estrogen responsive. And girls who are just starting their period have had like a couple of years of estrogen exposure. And it probably takes more along the line of like 20 to 15 years of estrogen exposure to develop polyps and fibroids. So it would be very unlikely to diagnose polyps and fibroids in somebody who's like 12 or 14. It's not unheard of. There are case reports, but it's literally case reportable. Menstrual abnormalities that require evaluation include menstrual periods that have not started within 3 years of thelarchy. So remember we said that the average time span of the pubertal arch is around 2 years. From the time of breast budding to the period starting is usually 2 years. If you've had breast development and you have yet to start your period 3 years later, that could be a sign of delayed puberty and needs evaluation. If you have not started your period by age 14 and you have signs of hirsutism, remember hirsutism is abnormal male pattern hair growth in a female along the chin, the chest, the upper buttocks, the thighs, the legs, etc. If you have not started it by age 14 and you have a history or physical exam findings suggestive of an eating disorder, excessive exercise, or excess stress. For anybody who hasn't started it by age 15, periods that occur more frequently than 21 days or consistently less frequently than 45 days, any periods that go longer than 90 days without occurring, or that consistently last more than 7 days, require more frequent tampon or pad changes, soaking more than one pad every hour or 2 hours, or are associated with a history of excessive bruising, easy bleeding, or a family history of a bleeding disorder, because all of those things could be potentially getting your wheels turning that the patient has a bleeding disorder. So for our case, we have a 13-year-old with no medical problem. She starts her period and she's changing one pad per hour for 10 days. She's passing large blood clots. She feels weak. Her mom takes her to the hospital where she's found to be tachycardic. That means that the heart rate is elevated. Orthostatic, meaning that her blood pressure drops with positional changes. And she has a hemoglobin of 6. So in terms of evaluating heavy bleeding, we use something called a pictorial blood assessment chart. That's what this looks like, and it can kind of help patients quantify and qualify how heavy their bleeding is, especially for girls who are new to having a period. They don't know what's normal, and especially if their parents, if their mom also had really heavy bleeding, she might kind of be over reassuring to say, oh yeah, that's normal, that's what my periods were like. But just because mom's periods are like that doesn't mean that it's normal. So when you're evaluating a patient, I think it's always good to use a PBAC just to kind of get a sense of where the periods are in a more quantifiable way, especially if you're going to track it, like you're going to start them on something. Moving down the line to better control their periods, this is a very concrete way to kind of see where they were before you started the medication and where they end up after. I also ask, in addition to asking, how long did your period last? How many pads or tampons do you use on an average day of your cycle? Are you passing large blood clots? Are you soaking through your pad and is the blood getting onto your underwear, your sheets, etc.? I also ask if there's any pain with the period, if they're sexually active, and if they have any history of STDs. And if they are sexually active and they don't have a history, make sure you ask, have you ever been tested? So this is all part of kind of my gynecologic assessment, and then certainly to look at their medications and see if they're on any hormonal therapy or anticoagulation. There's a screening tool to help identify adolescents with heavy menstrual bleeding who would warrant a screening for a bleeding disorder. And again, it's periods that are lasting more than 7 days. Patients who describe a sensation of flooding or gushing during the period, having a period where you bleed through a tampon or a pad in 2 hours or less. Have you ever been treated for anemia? Has anyone in your family ever been diagnosed with a bleeding disorder? For patients who have ever had dental work, have you ever had heavy bleeding with dental work, bleeding problems after any surgery? If you've ever been pregnant, did you have bleeding problems with your delivery or after a miscarriage? The screening tool is considered positive if one of the following 4 criteria are met. 1, that the period lasts consistently longer than 7 days, and the woman is reporting flooding, gushing, or bleeding through a tampon in less than 2 hours. If there is a history of anemia, if there's a family history of a diagnosed bleeding disorder, or if there's a history of excessive bleeding with a tooth extraction, a delivery, miscarriage, or surgery. Those would all be things that increase the likelihood that you would find a bleeding disorder if you looked for one. Like we said, in adolescence, structural causes of heavy menstrual bleeding, like fibroids or polyps, are very, very uncommon. Underlying bleeding disorders is second only to anovulation as a cause of heavy menstrual bleeding in adolescent girls. Heavy menstrual bleeding at menarche in adolescence is often thought of as a sentinel event, meaning a common first event at which time you would diagnose an underlying bleeding disorder. Bleeding disorders are not common, they're only like 1 to 2% of the population, but bleeding disorders are found in approximately 20% of adolescent girls who present for evaluation of heavy menstrual bleeding, and in 33% of adolescent girls who are hospitalized for heavy menstrual bleeding. The most common bleeding disorders in adolescent girls who present with heavy menstrual bleeding are von Willebrand's disease, platelet function defects, thrombocytopenia, and clotting factor deficiencies. Thrombocytopenia means low platelets, and that can be either congenital or acquired. Heavy menses can be the presenting symptom of a congenital thrombocytopenia like ITP or TTP. Von Willebrand's disease is a quantitative or qualitative defect in von Willebrand's factor, which functions in platelet adhesion in primary hemostasis. So in forming a blood clot, you have primary hemostasis where your platelets stick together, and then secondary hemostasis where your clotting factors are going to come and form like a fibrin mesh network between your platelets to stabilize that clot. Von Willebrand's factor is an important factor in primary hemostasis to help platelets adhere together. So in the absence of von Willebrand's factor, either because of a quantitative or a qualitative defect, you have a hard time forming that primary clot. That is going to present both with abnormalities in your von Willebrand's testing and abnormalities in your clotting pathways. So some coagulation studies that we send, there's one called an activated platelet thrombin time, and then there's one called a prothrombin time. The APTT is looking more at the intrinsic pathway for clotting, and that can be elevated with von Willebrand's factor. And then von Willebrand antigen activity, etc., are going to be abnormal. They'll either be low or they'll be dysfunctional. There are types of von Willebrand's that are quantitative, meaning you're missing some, but the ones that you have are normal. And then there are some that are qualitative, meaning that you have a normal amount, but they just don't work the way that they're supposed to. And then certainly there's also where you have a complete absence of von Willebrand's factor. That's type 3. That's the most severe one, and that's autosomal recessive, while the other two are autosomal dominant. Glanzmann's thrombasthenia, Bernard-Soulier syndrome, delta storage, pool disorders, those are all also disorders of primary hemostasis. And what would be abnormal in a patient's workup is what's called a platelet aggregation study. In the old days, we used to do something called a bleeding time to check for primary hemostasis. And now what we do is something called a PFA 100, which is an updated version of the bleeding time, essentially to see how long it takes for a platelet aggregate to form. There's also clotting factor deficiencies. So this is what would prevent that secondary fibrin mesh network from being laid down between the platelets and stabilizing the platelets. And that can be an absence of any of the major clotting factors, factor 8, factor 10, factor 9. Those are what are called hemophilias. And those would cause defects or abnormalities in the PT and the PTT. They would also cause abnormalities if you checked for the specific factor that's missing. Like we said, there's also thrombocytopenia, which is a low platelet count. It can be acquired or congenital. And then, of course, your platelet count would be abnormal. And then there's fibrinolytic pathway defects. Fibrinolysis is the process of breaking down a clot once it's formed. And that would throw off the studies that look at that. So approximately 1/2 of adolescent girls with bleeding disorders present with heavy bleeding at menarche. Others might not present until their periods become more consistently ovulatory. So don't rule out that it could be a bleeding disorder if the bleeding doesn't get heavy for another, 2 to 4 years. Of adolescent girls and women with an inherited bleeding disorder, 75 to 80% report having heavy menses as the most commonly cited clinical manifestation of their disorder. So again, this is really driving home the point that menses are a vital sign. And although classically regular heavy menses are associated with bleeding disorders, because adolescent girls are known to have irregular periods, prolonged menses because of anovulation superimposed on a bleeding disorder can cause really heavy and irregular bleeding. Of kiddos who have a bleeding disorder, 70% report passage of large clots and bleeding through clothes and sheets. If you guys remember the menstrual cycle chart that we looked at, where the follicle ruptures, releases an egg, and turns into a corpus luteum, that process can disrupt, and usually does disrupt, the shell of the egg, and that can cause some bleeding. When it causes bleeding that gets trapped inside the shell of an egg, that's called a hemorrhagic corpus luteum cyst. Those are really common. But if your hemorrhagic corpus luteum cyst is very large, or it causes intra-abdominal bleeding that's significant, that's called a hemoperitoneum if it ruptures, that can also be an indication for a bleeding disorder. Adolescents with heavy bleeding need treatment and evaluation, not just because their period is annoying or it's hard to manage, but a heavy period can cause anemia, which can impair school attendance, performance, decrease participation in sports, can even contribute to depressed mood and anxiety, and can certainly affect cognition, verbal learning, and memory related to fatigue. So let's go back to our case. I'm sorry this one picture is so blurry. I'll try to send you guys or post a clearer picture of this for people who want to get a better look at it. So for our case, the initial assessment is going to be to do a history, physical exam, look at the vitals, including orthostatics, that's checking the blood pressure when they're lying down and then when they sit up. Confirm the Tanner staging. So most kiddos in the pubertal arch will not start periods until they're about Tanner stage 4. Very uncommonly do periods start when you're Tanner stage 3. So confirm that this is in fact a period by looking at their pubertal arch. If they are Tanner stage 1 and then they claim that this vaginal bleeding is a period, that's a lot less likely, and it's more likely that it's coming from some kind of vaginal trauma, vaginal rhabdomyosarcoma, like there's something else causing this bleeding. With the history, you'll do a pad or tampon count, and then consider using the screening tool or the pictorial blood assessment chart that we looked at earlier. And then order labs before starting any kind of medication or transfusions. The labs that you'd want to order are a pregnancy hormone level, a blood count, a thyroid stimulating hormone, ferritin, which is a screen for iron deficiency, PT, PTT, INR, fibrinogen, von Willebrand's factor activity, and antigen. Those are all looking for bleeding disorders. Gonorrhea and chlamydia if sexually active. And then consider a type and cross to prepare for a blood transfusion if there's severe anemia or if they're hemodynamically unstable. And if there are signs of PCOS like hyperandrogenism, acne, hirsutism, then consider sending the labs for male type hormones, testosterone, DHEAS, prolactin, etc. Then In terms of stratifying whether or not you're going to keep this patient or discharge her to home with follow-up with GYN, it depends on the bleeding severity. So if there's active, profuse, heavy bleeding that's soaking more than one pad every 2 hours, or if there's vital sign abnormalities with evidence of hypovolemia with orthostatic hypotension, or if the hemoglobin is less than 8, you cannot discharge them home. You have to admit them for inpatient evaluation and management. If they don't meet any of those criteria, they can go home probably with a birth control taper, and then a close follow-up with GYN on an outpatient setting to review their labs, and then discuss a plan moving forward for maintenance therapy, either with continuous birth control pills if they don't have a contraindication to using birth control pills, or using a progestin-only method if they have a contraindication to using combined estrogen-progestin. Some of the common contraindications to using a combined estrogen-progestin pill is a history of a clotting disorder, migraines with aura, active liver disease, a known clotting disorder, even if they don't have a history, like a personal history of a clot, but they have a family history and they are positive for that gene. Those would all be things that would make you think that they cannot use estrogen progestin combined therapy, and that they would be a better candidate for progestin alone. If, like our patient who had a hemoglobin of 6, she's going to get inpatient admission. We'll consult a hematologist. This says consider a pelvic ultrasound. I'll tell you, I never do that unless they fail initial therapy, because structural abnormalities are so rare. And it's very unlikely that that's what's happening here. So we hardly ever get pelvic ultrasounds. We will consider a blood transfusion if they're hemodynamically unstable. The hemoglobin of 6, it's not like a slam dunk that you'll necessarily have to give a blood transfusion. And then I would usually start some kind of hormone therapy to stop the bleeding. So if they don't have a contraindication to estrogen, we would either start a birth control taper, like 1 pill 3 times a day for 3 or 4 days, and then go to 1 pill twice a day for 3 or 4 days, and then go to 1 pill daily. Birth control pills can be very nauseating, so it's also important to start an antiemetic. And then while they're admitted, you'll do their pad counts and see what their bleeding pattern looks like. If the bleeding continues, then you could add on an anti-fibrinolytic agent like TXA, which I'll talk about in the next slide. Again, consider consulting hematology if you haven't already. And then you can also use a mechanical form of stopping bleeding with balloon tamponade. So I've done that in the OR before, where you use a guide wire actually to get a Foley balloon into and through the cervix. And then you inflate the Foley balloon to put pressure on the walls of the uterine lining. If the bleeding stops, then once their hemoglobin and bleeding are stable and they're tolerating oral therapy, then they can go home on the medication they're on, but they have to have scheduled follow-up within 7 days. And again, if they have estrogen contraindications, like migraines with aura, high blood pressure, a previous clot, a transplant, congenital cardiac anomalies, or an increased risk for blood clot due to like a family history, then we would do a progestin-only therapy like oral Provera, pretty high dose, like 20 milligrams 3 times a day until the bleeding gets better, and then we would taper it down. And I already said this stuff, but this is just a much clearer picture of what I said, talking about that initial branch point of how heavy is the bleeding? Can you do outpatient management, or do they need inpatient management? Do they have estrogen contraindications if they're admitted inpatient? Would you do estrogen therapy or progestin therapy? And then what to do while they're admitted inpatient? What are you evaluating for as discharge criteria? This is a pathway that you guys are going to know and love eventually. It's the clotting cascade, and you guys are going to study it a million times in your life if you haven't already. There's an intrinsic and an extrinsic pathway. And what I just want you to focus on is the fibrinolytic system, which is how we actually break down a clot. So there's plasminogen activating inhibitor, and then plasminogen activation. And plasmin is the final protein product that breaks down cross-linked fibrin, which is that mesh network between platelets, and breaks it down into fibrin degradation products. That's important to know because one of the medications that we use really frequently for kiddos who have bleeding disorders and heavy menstrual bleeding is a medication called TXA, tranexamic acid. And it's an anti-fibrinolytic, meaning it's stopping the breakdown of a clot once it's formed. It does not promote excess clot formation. It just stops the breakdown of clots that have already formed. It essentially is a competitive inhibitor with fibrin for the binding sites on plasminogen, which is what breaks down the fibrin mesh network between platelets. It is not, again, it is not prothrombotic, does not encourage the formation of clots. It's very well tolerated. The most common side effects are like nausea, diarrhea, some orthostatic reactions. It's inexpensive, it's heat tolerant, and it has almost no contraindications. We use about 1 gram 3 times a day during heavy menstrual bleeding. Typically we use it for 5 days, but you can use it for up to 10 days, clinically speaking, if the period is lasting longer. It's a relative contraindication if they're at an increased clotting risk with immobility, obesity, or a known clotting disorder. Women with heavy menstrual bleeding have higher plasminogen activator levels, meaning they have more plasmin around to break down that mesh network. So TXA really should be considered amongst the first-line therapies for heavy menstrual bleeding. It leads to a reduction of menstrual loss by about 50% and an improvement in quality of life. It's actually better at reducing heavy menstrual bleeding than combined hormonal contraceptives or progestin-only options alone. It's comparable to a levonorgestrel IUD, and it has no increase in adverse events. For patients who have von Willebrand's disease and heavy menstrual bleeding, so remember, they're the ones that are missing a necessary factor to help aggregate the platelets initially in primary hemostasis, they might benefit from the use of TXA and desmopressin, which actually encourages the release of von Willebrand's factor from like the little part of the cell where it's held. I can't remember the name of it, but within platelets, there's a place where the von Willebrand's factor is released, and desmopressin encourages the release of more von Willebrand's factor. So desmopressin, obviously, it only works if you have a quantitative defect in von Willebrand's factor. If you're qualitative, it doesn't work as well because you're releasing more of a dysfunctional product. But it just depends on how dysfunctional your von Willebrand's is. If you have more mosaicism within the qualitative defect and you have some that's normal, the desmopressin could help, but it will not help with type 3 where there is no von Willebrand's factor, and for that you actually have to give an infusion of von Willebrand's factor. For patients who have a low platelet count, occasionally they actually need a platelet transfusion, but that's usually only if their platelets are less than 20,000. And then certainly to treat the underlying condition. So if they have an immune thrombocytopenia, then you would give them steroids and treat the autoimmune response. If it's like TTP or HUS, you would treat that supportively with steroids, IVIG, things like that. And then you can always consider adding on TXA to help with the bleeding. And that's pretty much it for heavy menstrual bleeding at the time of menarche. Some of the things to think about, some of the unique options for management in this patient population, And certainly just driving home the point that menses are a vital sign. And I think it's really important for any clinician, no matter what field you go into, 50% of your patients are women, and screening for abnormal periods should be as bread and butter as taking a blood pressure. So I want to thank everybody for joining, and this is the fourth lecture I've done for web shadowers, and I think it's going to be my last one. I hope everybody has had a great time with these lectures and has learned something, and I'm going to stop sharing and open up the room for discussion. I also have a very low battery on my computer, so if I cut out suddenly, it's because my battery died. Someone asked me about my Fulbright year. How did I inform my medical school that I wanted to take a year off? And were there any cons to taking a year off? So I'll tell you, my med school was super, super supportive of it. I mean, a Fulbright scholarship is a pretty competitive State Department funded scholarship. I essentially had a scholarship through the American Embassy in Tunisia the American Embassy in Jordan. And my school was very supportive of that. And they were really excited about me going. And I was a traditional path medical student, so I didn't take any time off in between college and medical school. So I kind of felt like I needed to take some time off. Like I needed to do something different. I wanted to kind of get a little bit older, mature, do some things, travel, see the world. And I think it was actually really an asset in applying for residency. It was probably the thing that people asked me about the most. Eating disorders. Someone asked me how do eating disorders affect the menstrual cycle. So eating disorders put the body into a mode of starvation, essentially telling the body that there's this major stress going on. There isn't enough food available. So that shuts down the pulsatile release of GnRH from the hypothalamus, which decreases the secretion of FSH and LH from the pituitary gland. And the reason for that, I think physiologically, is because if you're not eating enough for one, your body is like, you're certainly not going to be eating enough for two, and it's not the right time to get pregnant. When there's a nutritional deficit like that, it's really an energy imbalance, and the body is deciding, should I use the energy that's available to keep my heart beating and blood flowing to my brain, or should I keep blood flowing to my uterus and my ovaries? And ultimately, the heart and the brain win. So you have to have an appropriate amount of energy to sustain all of the different functions of your body. And if you have a nutritional deficit, your body's going to cut out your period. Good references that I really like a book called Blueprints, and I also like the I think it's called Case Studies in OBGYN. I used those when I was a medical student. There's a more detailed one if you're thinking about doing OBGYN called Beckman's for medical students. It's like a floppy paperback, but has a lot of detail, and I actually still look at that today. I really liked Beckman's. What's my opinion on the lack of access to sanitary products in many communities around the world? I mean, it's awful. Period products are filed under cosmetic products, and there's actually like a cosmetics tax on like pads and tampons. It's literally like a tax to be a woman. And these products are as essential as toilet paper. They're as essential as water. Essentially, it's like a necessary product and activity of daily living for women. So that's really truly a shame, and obviously speaks to the people who are in charge and who's sitting at the table making those decisions. So there are a lot of organizations that are working on improving that, and trying to fight to make sanitary products around the world accessible, available, free, starting from jails to villages and underserved and under-resourced areas. What factors determine the intensity of the period? Is it simply dependent on the person? So yes, it is dependent on the person. I think if you remember looking at the cycle, the menstrual cycle that we talked about, everybody's body is going to recruit follicles in a different way, depending on their pulsatile GnRH being secreted from their hypothalamus, what's their level of FSH like. There's so many hormonal and dietary and stress factors that affect your HPO access. So those types of things can affect how heavy and regular your periods are. But in general, I would say it's pretty genetic. Like, some people have heavy periods that are normal, and some people have really light periods that are normal. And not all heavy periods are pathology, but there is that screening tool and those charts that we try to use to try to stratify how heavy is too heavy. But if you're heavy and normal versus being light and normal, that's mostly genetic. How is the experience of men in OBGYN different than women in the profession? I have a lot of colleagues who are men, and we really respect and love their role in our field. And I would say, yes, it's becoming a more female-dominated field, but I think there's no reason if you're a man who's interested in OBGYN not to go into OBGYN, because as long as you're caring and passionate about the field and you have a good bedside manner, you will succeed. Yes, you will succeed. You will be exceptional. Why does it matter if they have a history of bleeding after a tooth extraction? Because if you have a bleeding disorder, you probably would bleed after a tooth extraction. So it's all reflective of the same pathology. It's likely if you have a problem forming a primary clot or a secondary clot, that would have affected your ability to clot after a tooth extraction. So that can be an important part of the history that can kind of perk your ears to listen a little bit more closely for a potential bleeding disorder that would require a workup for a bleeding, or to listen for a history for a period that would require a workup for a bleeding disorder. When having menstrual abnormalities as a child, is it possible to get pregnant later on in life? Absolutely. Remember that there's so many different potential causes of abnormal bleeding in adolescence, and most of those causes don't relate to infertility, and most of them are not chronic, but are more transient causes of abnormal bleeding, primarily being immaturity of the HPO axis, or a bleeding disorder that's not going to affect your ability to get pregnant. How often do you see cases of sexual assault? I used to, in fellowship, have a sexual assault clinic, both for patients who were victims of sexual abuse, trafficking, child abuse, neglect. And we used to rotate through that clinic to provide contraceptive support. And certainly we had colleagues in that clinic who provided more of like the social work support, the resources to get help and get a network of people who can help you get out of the circumstances that you're in. But our role was really to kind of screen for contraceptive needs, screen for STDs, treat STDs as we found them, and things like that. But it's sadly a lot more common than most people would think. What are your thoughts on Diva cups? They're cool. They're good. I mean, if people want to use them and it works well for them, there's no reason not to. There's no gynecologic downside to using a Diva cup. How does the menstrual cycle affect mood disorders? That's a great question. There's something called PMDD, which is a perimenstrual dysphoric disorder, which can be an exaggeration of mood dysphoria, either anxiety or depression, that can be debilitating and affect quality of life with the premenstrual period. So PMS is usually self-limited, lasts for 2 to 3 days, doesn't affect quality of life or activities of daily living, but PMDD can. That occurs in about like 10% of patients and can be treated with SSRIs or birth control pills. I favor using birth control pills if someone also has contraceptive needs, but lean towards SSRIs if they don't currently have contraceptive needs. And then certainly if you start a birth control pill and it's not enough, you could always add on an SSRI, which is an antidepressant. What are the long-term effects of eating disorders on menses? Are the effects reversible, or can it lead to sterility? So the long-term effect of eating disorders on menses, like we talked about, puts you into that starvation mode, shuts down your HPO access. Is it possible to reestablish your energy balance? Absolutely. Is it difficult to? Absolutely. Eating disorders are one of the hardest things that we treat and see in our clinics. I have a patient who's 24 years old and she's 65 pounds right now. And she's always bargaining with, I told her she should take calcium and vitamin D. Her bones look osteoporotic. She hasn't had a period in a year. We talked about what that means and why that's dangerous. And she's bargaining with me about the calcium and vitamin D supplements because of the calories in them. I mean, it's such an uphill battle. It requires really a multidisciplinary team approach with psychologists, with social workers, GI psychologists, usually a GI on the team as well. We're a part of that collaborative team effort to help care for these patients. But it's really a long-term struggle, and there's not a pill to fix it. So it's not like you can just give hormone replacement therapy because the body is in a heightened level of stress. So that increased cortisol is also eating away at your bone. And you can't just give a hormone pill like a birth control pill to replace the estrogen you're missing from not having a period. It's not going to work. It's not going to fix your bones. So you ultimately just have to establish normal energy balance, meaning improve your intake, decrease your outtake, and reestablish with your body that you could support eating for one, and if you needed to, could support eating for two. How do I handle patients with a history of sexual assault, rape, or PTSD? I actually screen for it in every visit. I ask every patient I'm seeing new for the first time, do you have a history of sexual assault, domestic violence? Have you ever been touched in a way that made you feel uncomfortable? Tell me more about it. And I tell them that the reason I'm asking is because I'm a gynecologist, I do pelvic exams, and I really appreciate knowing what their background is, where they came from. If pelvic exams are triggering for them, I want to know, so that we can certainly provide more support through the pelvic exam, give the patient as much autonomy as possible. They don't want to do the pelvic in the first visit. They want to come back and do it at a different time. They want to kind of dictate the timing and things like that. Then that, I think that can be a really important part of being a gynecologist for a patient who's been a victim of sexual assault, rape, or PTSD. So I really try to know that about all of my patients, if it's in their history or not. Is it considered an abnormality if on birth control the person never bleeds? No, not considered an abnormality, because remember, progestin is stabilizing the lining of the uterus, and it also prevents it from growing further, because it's laying down that grout and preventing additional bricks from being laid. So if you've been on birth control for a long time, the lining of your uterus is both thin and stable, and a lot of people just don't get a bleed even if they take a consistent break. And if you don't take a consistent break and you don't bleed, it's really not a problem. A lot of people skip the sugar pills intentionally to not have a bleed, and the only downside of that is that you can increase your risk for breakthrough bleeding because your lining can actually get too thin without a break. And then you can kind of have more of a dysfunctional bleeding pattern because the lining of the uterus got so thin that the vessels under the surface of the endometrium are kind of exposed and bleeding more easily. So if you take a couple of days off of your birth control pill, you'll have like 3 or 4 days of just being really estrogen forward, more like follicular phase hormonal profile. And you'll lay down a little bit more lining to your uterus. And that'll help reestablish a healthier lining that doesn't have as much breakthrough bleeding. But if you're having no breakthrough bleeding and you're taking a pill continuously and it's working for you, there's no downside to that. My typical day at work is very variable. I'm usually in clinic from like 8 to 4, and then go home and do some charting, answer some results, call some patients, do that kind of thing. And then one day a week, I'm on call in labor and delivery, which is where I was last night. And today I'm post call. And then like one day every other week, I'm in the operating room doing cases that ranged from minors, like, removing a vaginal lesion or putting in an IUD in the operating room for a patient who has developmental delay, doing a tubal ligation, doing an ovarian cystectomy, and then also do some majors like abdominal hysterectomies and robotic hysterectomies. And that's all the time we have for questions today. I hope that was helpful for everybody and that you guys all got a lot out of this series. And of course, feel free to contact me if you have any questions about my background or my track. But now my low battery light is flashing, so I'm sure my computer is going to turn off at any moment. So thank you guys so much for tuning in and joining us today. And I've really enjoyed creating these lecture series for you guys, and thank Web Shadowers for creating an opportunity for docs to have so much outreach to pre-meds, because I really truly love teaching, and this has been a really fun outlet for me too during COVID. So have a great day, everybody, and a great weekend, and I hope to hear from you soon. Bye-bye.
Thank you so much, Dr. Elborno. This was a wonderful presentation. We've loved all the times you've joined us. Everyone make sure to follow her on Instagram. Her Instagram is @thegirlyguy now. Additionally, thank you all for attending. The link to the Google form has been posted in the comments. There was a little bit of a technical error with it, but it should be fixed now. If you please fill it out within the next 30 minutes, you'll be able to receive verification for your attendance. We'll leave it open until around 10:37 just to make sure you have a full 30 minutes to answer. Thank you so much, everyone, and I hope you all have a great day.